Good morning. My name is Ibrahim Wada. I am the Executive Director of Advocacy for Civic Engagement Center. You're welcome to the 9th House Sectoral Roundtable session on health. This is the first session, and today we'll be examining Re-prioritising government spending on health in the context of the Abuja Declaration of 2001. So we have a full house. We have a lot of resource persons who have agreed to lend their voice to this conversation today. So we'll observe all protocols. Honorable Benjamin Kalu, the Chairman of Committee on Media and Public Affairs, the spokesperson of the House, here present. Honorable Tanko Sununu, the Chairman of the House Committee on Health Institutions, present. All members of the 9th House of Representatives who are present and who are going to be joining us. Dr. Walter Kazadi Mulombo, the country representative of the World Health Organization. Dr. Ibrahim Wada, the founder of NISA Premier. Dr. Alawode Gafar, the program director of LISDEL. The officials and representatives of the professional bodies and associations in the health sector who are also here present, and all healthcare practitioners and members of the public present. This event is going to be hosted by Dr. Nkem, who is a seasoned health policy expert with over 25 years experience. In fact, it is an honor and privilege to have her driving this conversation. And it will also be co-moderated by Dr. Chioma, who will also be assisting her. And so without further ado, because of time, we have just 2 hours. I'll hand over to Dr. Nkem.
Okay, so good morning, everyone. It truly is an honor to be here. We have such a distinguished panel. I would like to start with the spokesperson for the House of Representatives, that is to give us an opening remark. Honorable Benjamin Kalu.
Thank you. Permit me to stand on the protocol established by Barrister Ibrahim Wada for the want of time. I will go ahead with the welcome address from the Media and Public Affairs of the 9th Assembly on the median 9th House Sectorial Roundtable section. On July 11, 2019, during his inaugural speech at the commencement of the 9th House of Representatives, the Honorable Speaker, Representative Femi Gbajabiamila, announced the theme of this assembly: nation building, a joint task. This mantra has motivated us to work across party lines in the interest of national development. But above all, it has driven our commitment to enhance citizen participation in our legislatures as well, because a lockstep approach to policy development with Nigerian citizens is of course nature of this arm of government. One of the general principles of the updated legislative agenda of the House is to foster engagement and collaborations with CSOs and constituents with the strategic goal of enhancing citizen participation in the legislative process. These commitments are in line with the basic tenets of democracy and participatory governance. It is therefore in furtherance of this legislative agenda of the House and the mandate of the Media and Public Affairs Committee that it was deemed necessary to undertake periodic sectorial roundtable as a way to foster citizen participation in the legislative process and to enable the House fill the socio-economic pulse of the nation. The 9th House Sectorial Roundtable section is an initiative to drive monthly interactions between the House and the various socio-economic sectors. It will bring to the dialogue table experts like yourselves and stakeholders like yourselves from the citizenry, private sector, NDAs, and legislative committees to critically examine the real-life performance of the various socio-economic sectors to identify and address gaps, issues, their actions, legislative amendments, and other interventions. Through this program, we have chosen a proactive rather than reactive approach to public engagement. We have chosen to work with the people to ensure that their recommendations and feedback shape the legislative and policy trust of the House. Mindful that this must not be yet another talk shop, we have worked out a detailed follow-through strategy to ensure that interactions with each sector remain ongoing throughout the life of this assembly. Ladies and gentlemen, at the end of this roundtable, all deliberations and recommendations will be reproduced in a document we have called the Green Book. This will be presented to the leadership of the House to serve as a guide to institutions in the relevant sectors. With each sections, between the committees on health services and health institutions and key sectorial stakeholders who will, with the support of each center, participate in the development of bills, motions, and measurable indicators for our oversight activities. Ladies and gentlemen, it is no secret that over the past 2 decades, the reputation of the Nigerian legislature has been shrouded in controversy, with many citizens skeptical of the role in national development. Many Nigerians hold the view that the legislature has not shown a significant and genuine commitment to the social, economic, and political well-being of the country. We believe that this pessimism stems from a yearning for transparency and participatory governance. Therefore, beyond expediting this our pursuit of national development, we hope that the sectoral interactions will demystify the legislature, ensuring that we are seen for what we are, messengers of the people and compatriots in progress. In concluding, I must thank the Honorable Speaker of the House, Representative Femi Gbajabiamila, for his resolute leadership and commitment to a people's parliament. I thank my colleagues, the members of the Media and Public Affairs Committee, for their support, as well as the chairpersons of the committees on health services and health institutions, Yusuf, Sununu, and Representative Pascal, will be for their participation today. I must also acknowledge the participating members of the executive arm of government, including the Honorable Minister of Health, Dr. Sagir Ehanire, the DG of the Budget Office, Mr. Ben Akubeze, and the DG of NCDC, Dr. Chike Ihekwazu, who have demonstrated their commitment to the mutual respect and harmony that exists between the arms of government in the interest of national development. Though we are different arms of government, we are one government. I welcome all speakers and participating stakeholders of the health sector to the event, and I thank you for this opportunity to engage. Finally, I must commend the vibrant young people of each center for this partnership in this vision, for their passion and commitment to fostering civic engagement and citizens' participation in governance, while encouraging other sectors to brace for engagement with the House. I seize this opportunity to call on CSOs and other development partners to support our endeavor to produce and promote transparency, accountability, participatory governance, and to strengthen our democratic institution. I wish everyone a very nice, fruitful deliberation. Thank you, and God bless you. Benjamin Okezie, Kalu, Chairman, Media and Public Affairs. Thank you.
So thank you very much, Honorable Kalu. We really do appreciate the opportunity to have our pulses felt by the 9th Assembly and to have the policies that are emerging from the House be more, speaking more to our and to the political agenda as set by others. So thank you so much for that. Okay, so next we are privileged to have the chairman of the Committee for Health within the House of Representatives, Honorable Yusuf Sununu. Sir, you have 10 minutes. Thank you so much. Go ahead.
Well, thank you very much. Okay, first of all, let me start by recognizing the presence of the chairman of House Media on Publicity, my brother, my friend whom yesterday I've described as an associate doctor, Honorable Benjamin Kalu. I also want to recognize the organizers for this online meeting for a job well done. I want to specifically pay a respect and give honor to whom it is deserved. A renowned gynecologist, obstetrician, famous in assisted reproductive techniques in the country, a mover of private-public partnership in the country, and a good example of disciplinarian, an example for a doctor to be, whom I always pray to be when I grow up. That is my mentor, Dr. Ibrahim Wada. You are most welcome. Permit me to start by saying that the proactiveness of Mr. Speaker has really moved healthcare level to where we think hope is gradually regaining back. We all know that his proactiveness have saved this country in terms of healthcare tragedy that will have befallen this country. First, in our inception, the first that we are battled with was to see how we can bring down and reduce the incessant strike that characterized medical practice within the country and generally the healthcare delivery system. And that we have succeeded in resolving most of the problems that are contentious, especially those ones that has to do with training, so as to ensure that we have produced specialists in the country. Because our hope remains on how we pass baton from our elder ones like Dr. Wada here to those of us who are oncoming, and how do we manage to give it to the younger one? Otherwise, the chain will collapse, and we do not hope that. And that's why today's discussion is very important, to see how we create a healthcare system that is resilient enough to stand any shock that either anticipated or unanticipated. Therefore, I want to start by saying that, thanking the convener of this very important discourse that will provide an enabling ground for us to x-ray healthcare delivery in order to make actionable plan for future utilizations. Globally, healthcare has been receiving attention. Among the numerous considerations was in September 2000, when 189 head of states of African region convened in Abuja, Nigeria, and adopted the Millennium Declaration. Make a commitment in 2015 to ensure that healthcare received the highest allocation of at least 15%, which is now regarded as Abuja Declaration. As part of that declaration also is that the healthcare sector should be improved through assistance by developing partners in improving nations with poor health capacity to increase their gross national product by at least 0.7%. The 2000 healthcare pledge made by Nigeria and its fellow African Union countries is called the Abuja Declaration. The failure of many African nations to adhere to the proclamation is among the reasons of the worsening of the state of healthcare delivery in the continent. This can further be justified because of the significant improvements seen in countries that made progress to allocate at least 15 or more than 15% of their budgetary allocation to health. Smaller countries like our neighbors here in the Niger Republic, Burkina Faso, has made a lot of effort in ensuring that they have stick to Abuja Declaration. And we have seen a lot of changes in their indices. The decay is worse in countries with higher out-of-pocket spending when the need for restoration of health arises. For instance, in Nigeria, up to 70% of procurement of healthcare when one is ill is through the out-of-pocket purchase. And this has great significant impact on the country's gross domestic product because a healthy nation is aware. And when the health of a nation depends on average individual of that nation putting his hand in his pocket to secure his health care, it becomes an issue. Here I went as an obstetrician. I witnessed a situation where a farmer came to the hospital. He has to sold out his farm in order to pay the services rendered during the cesarean section for him to get a living baby. He has a nursing mother, a baby, and then livelihoods depend on his farm that he has so far sold just for him to be a recipient of a child. That has put him or pushed him to an extreme level of poverty. And that should not be what will be cited as an example of healthcare delivery in any part of the world. Further worsen the situation, the spread of COVID-19 like a wildfire and its capacity to wreak havoc across the world has made the question of Abuja Declaration more relevant. In Nigeria, coronavirus pandemic has revealed decay in infrastructure. We have seen all this. In fact, this became obvious when it happens. It also shows that there is acute of critical and life-saving equipments like functional ICUs. And even as at that time, we cannot be proud at the onset of pandemic in Nigeria to say that we have more up to 30 functional ICUs. What I mean functional, fully equipped with ventilators and all necessary equipments and gadgets that is needed. That shows really a wide gap in our healthcare delivery system. It also showed an acute poor human resource for healthcare. This, I keep on saying that what will happen post coronavirus may likely be a storm if we have not come together to address the issues. Because we all know that now many green postures that younger ones would like to move to enhance their skills and also to better their life have lost so many of their health workers, and very soon advert will be coming from this. So the brain drain, if we haven't come together like this, may be a brainstorm for us. And I do hope that we can all realize that so that we can put our hand on the deck and work to prevent what may be described as catastrophe in healthcare resources for us. It also shows that there is a worsening of pocket procurement for healthcare in the midst of rising poverty, unemployment, and literacy. This began because the system is not that resilient. A lot of normal services that average Nigeria is almost in the first few weeks non-existent. Most of our public hospitals shut down because of fear of nosocomial spread of pandemic among the health workers due to a paucity of PPEs. Many of our private facilities have to shut down for fear that admitting a corona patient may stigmatize their healthcare facilities. Thereafter, a patient may not likely come to avail the services of that hospital. So these are all major issues that we must give a contradiction. The failure to implement the Abuja Declaration has continued to render our healthcare system fragile. While resources mobilization and allocation are still major issues, there is low priority given to the primary healthcare in Nigeria. This is a very important issue. This led to major public investment and spending to be concentrated in tertiary healthcare, such as teaching and federal medical hospitals, leaving less than 40% of healthcare expenditure to primary healthcare. This shows the emphasis of curative over preventive approach healthcare delivery. And I think it's a time that we must realize that and change focus so that we can have a system that can be proud of. There is also a greater emphasis of curative services, which I've mentioned earlier. This is through creating public health approaches, receiving less attention. Also, we have an overdependence on external rather than domestic funding of healthcare. These have further prone the system to a lot of weaknesses and thereby reducing capacity to withstand little shock. We are all living witness. When the status quo was challenged, the WHO has to go down. When the president of America decided to hold funding of the United States, everybody went helter-skelter because the healthcare in the whole world would be distant. The only reason is that because we have an overdependence on foreign funding, we can look at a lot of alternative funding of healthcare delivery that we can do to boost our own internal funding. We have also seen that the economy world over is now going almost down. So the ability of Nigeria to access international funds has significantly reduced because those that we are depending on are also depending on, they are also leaking way out because their economy has been down for over the period of this pandemic. It is therefore pertinent to call on all of us to use the lesson derived from the pandemic in building a resilient health system. A health system can be defined as assembly of public and private organizations, institutions, and resources mandated to improve, maintain, or restore health. On the other hand, time?
So you have 1 more minute to round up.
On the other hand, the system can be defined as on the other hand, strengthening the health system involves significant purposeful effort to improve performance. This required reform of health system, how it operates. The overall goal is to achieve universal health coverage. That is the capacity of all people to be able to receive needed health services of sufficient quality, which without being pushed to extreme poverty, as I stated earlier. For healthcare coverage to be universal, there shall be equity, service use, quality, and financial protection. In the post-COVID era, we shall aim at not only ensuring a health system that guarantees achieving universal health coverage, but also a healthcare system that is resilient. The resilience of a health system refers to its ability to withstand health shock while maintaining routine function during pandemic or epidemic or any other challenges that may occur. The lack of this capacity in our health system at the onset of COVID-19 pandemic has nearly brought the healthcare delivery on its knees, with a lot of patients, especially those with chronic diseases, losing regular follow-up, interrupted emergency services, and even shutting down some facilities, among others. Permit me to emphasize that we need strong local, national, international commitment to achieve this, and we must all come together to ensure that we work together in achieving at least 15% of nationally budget allocated to health. I thank you for the opportunity given to me to say my keynote address. Thank you very much.
Thank you very much. And we really look forward to hearing during the interactive session how the Ninth Assembly is thinking about how to overcome some of these challenges that we're facing, whether it is the adequacy of human resources, or whether it is the out-of-pocket expenditure that people are having to endure, or whether it is the the lack of functional ICUs, all stemming from the poor funding that we have for health in Nigeria. So we're really looking forward to hearing how the Ninth Assembly is changing the dynamics around that. So thank you very much for your address. Okay, now we will be moving to the specific presentations. I will start with Dr. Walter Kazadi, since he is here. Or should I say Dr. Ibrahim Wada, who is, I know he's prepared. So we will, let me just introduce him. Dr. Ibrahim Wada is a chief consultant gynecologist and the founder and CEO of NISA Premier Hospital in Gariki. NISA Premier Hospital, Gariki Hospital, NISA Pharmaceuticals, and Cell Genomics in Abuja. He is also the director of the Institute of Medical Sciences in Africa, IMSA. He also holds many postgraduate medical qualifications, such as FRCOG, which is a fellow of the Royal College of Obstetrics and Gynecology. He's a fellow of the West African College of Surgeons, and he also has an MBA. He first became a consultant gynecologist at Bourne Hall Clinic in Cambridge, the UK, which is the world's first fertility and in vitro fertilization center. He later returned to Nigeria and became the Director of Clinical Services at the National Hospital, Abuja, in 2002, and later became the Pioneer Medical Director of Gariki Hospital, the first wholesome private and public partnership with the Federal Capital Territory. And I know we'll be talking a lot about public-private partnerships and how that has a role in changing the dynamics around the healthcare financing. So, Dr. Wada, you're very welcome, and you are free to start your presentation. Your presentation is 8 minutes, and I know you will do your best to keep time.
Thank you, Doctor, and my friend and colleague. It's a pleasure. Let me honor our country because we have the greatest people anchoring many facets of our life. Our democracy is protected by the institution like the House of Assembly. And what better people to lead than the ones that we have, young, able. I'm waiting for my slides to come up. And also to say thank you, my friend, Dr. Sununu, who is the chairman. And I must also recognize the Minister of Health. I'm waiting for the slides to come up, please, to share the slides. Are you working on it, Nkem?
I think there's another co-host that will be doing. It's coming up. It's coming up, sir.
Okay, good. So the Honorable Minister of Health had a very difficult time in our national life. The pandemic also needs to be recognized and encouraged. There is no 100% solution anywhere in the world. And the coming together of Nigerians to protect these institutions and the people that are leading them. I'm talking about health in Nigeria with particular emphasis on public-private partnership. And I would like to go on to the next slide. Yes, and it shows we will define public-private partnership, PPP, and how it relates to the Abuja Declaration, what's good about it, how can it help our health system, what lessons have we learned so far from the Garki Hospital PPP example. Next slide, please. The whole talk about the Abuja Declaration is how to bring more money to improve our health systems. All African countries were represented by heads of states, and all of it to strengthen the health system, prepare it to withstand any issues like the pandemic we are in now, improve the quality, access, affordability of health. But what is important is that many assessors are saying Nigeria is not on track for all the things that we signed at that Abuja Declaration 20 years ago. And when people like me look back in history, we remember when we used to say in the 80s, health for all by year 2000. And then in 2000s were like Millennium Development Goals, Sustainable Development Goals. A lot of it, we've not achieved maximum for it. What does that mean? It means if we're to get the best kind of healthcare that we deserve, and we deserve the best that any human being does, we must look for additional sources of funding as given. But in particular, I am going to talk about adding funds to the health systems via public-private partnerships. Next slide will show us what it means, PPP. Next slide. Public-private partnership is the collaborative partnership between a government agency and the private sector, and that's to target public good, either to deliver some goods or services to that public or build bridges, houses, etc., etc. They are in use in all parts of the world and growing for that matter. So it's not just Nigeria. We need to learn more about this to get the greatest benefit we can out of it. Next slide. The government and the private sector joining hands for common good or public good has good sides and it also has bad sides. I want to point out that the good sides are really good. Access in terms of healthcare, for example, it increases access, it increases the scope of available services, quality, gets the best manpower because it's able to pay the manpower, and the overall thing is that the quality of life of citizens are enhanced. The other part is, yes, there are bad sides, but these bad sides also have solutions. The public sees that if government and private join hands for anything, it is called privatization. That means government is selling their assets away. The true answer is no, government continues to own those assets. They belong to the public. Others say, look, if government and private join hands, then high cost of providing the services. That is why you have the equity part, which is like health insurances. You don't always have to pay out of pocket. You are aware of universal health coverage, UHC, that Nigeria is working towards. These are ways of mitigating against cost issues, sharing the burden. Thirdly, people think the government is leaving its responsibility to the private sector. No, the union between government and private can only lead to strength rather than weakness. Next slide. Next slide, please. So I've tried to compare Nigeria's health system in terms of primary, secondary, tertiary healthcare. You know that primary is local government, secondary is state government, tertiary are these research and training institutions. Look at the outcomes for all of this. Primary healthcare means that each citizen of the country has a doctor or a door that he calls, if I'm sick, I go there. That's not happening. That's why we put question mark. The private sector, which is delivering 60–70% of healthcare, is coming to the rescue. There are bad sides and good sides. But when there's PPP at the primary care level, you can only get good out of it. Ditto secondary and tertiary level cares. It will prepare the nation better for preventive health, delivering immunizations, tackling pandemics. It will stop the issue of doctors on strike and nurses on strike and brain drain. It will strengthen the use of national health insurance and the universal health coverage that we are all looking for. Of particular problem is the fact that our rural areas are really weak. The healthcare system there is still the traditional way mostly, and only when public and private join will we expect to improve upon that. Next slide, please. So having said that, what lessons have we learned from the 12 years of Garki Hospital as PPP? Remember, there are good sides and there are bad sides. The good side is we have been able, without any government money participation, to keep that hospital going for the 12 years. That means government's money can go to tackle other weak areas of our economy. We've brought in high-level technology, including the MRIs of this world, highly specialized manpower locally, including the Nigerians abroad with expertise that we've brought over the years to improve quality of care. Every year we record more and more people using Garki Hospital. It's very, very efficient compared to the general government hospital. That means there's less waste. On the other side, we are training human beings, doctors, nurses, and even formal postgraduate training of doctors. The government's role is mainly regulation by the government agencies and by the government ministries. That way, there is a balance of positive and negative. So there's much more accountability of the funds that come into the project. And accountability is it not just bring money, but if you waste the money, you get nothing out of it. Finally, what conclusions can we make from attracting extra funding to health via PPP? Next slide. I'm here to let you know that if we are to reach the desired goals of Abuja Declaration, of MDGs, of SDGs, of universal health coverage, public-private partnership is necessary. Public-private partnership, PPP, is inevitable. PPP is also desirable. It is a tool for fast-tracking health systems improvement. This has been clearly demonstrated in Garki. Also, I can share with you that the advantages of the public sector coming together with private sector far, far outweigh the disadvantages that I've shown you can be corrected by health insurance and protection of government assets. Thank you for the opportunity to address this. Have a blessed day. I'm really grateful to be called to talk. Thank you.
Thank you so much, Dr. Ibrahim Wada. That was very succinct. I really love the way that you summarized everything at the end, saying that PPP is not only desirable and advantageous, but it's necessary and inevitable. I think that's a really powerful statement to close on for your section. And I know that the participants are looking forward to the opportunity to ask you specific questions, including myself, about how PPP is working in further detail. So thank you very much for that. Next, we're going to have Dr. Walter Kazadi. Dr. Walter, can we see your face, sir, and say hi?
Hi. Thank you, okay. And happy to join the talk, and thank you for inviting me.
Thank you. Thank you so much. We love having you here. Let me just introduce you to everyone. Dr. Walter Kazadi Mulombo is a medical doctor and public health epidemiologist. He has been the WHO representative to Nigeria since the 18th of June 2020, and he previously served as a WHO representative to Burundi. So we're happy to have you, and at a time such as this, where Nigeria is in so much, in such a need for expertise in the way that disease is spread, we need to be able to do modeling regularly. So we're so glad that you're in country at this moment. So, sir, I know you have a presentation. Your presentation will be similar, so it's also 8 minutes. And so, so you can go ahead. We look forward to hearing you.
Thank you. In the interest of time, I prefer to make remarks, but also still addressing the question for the conference, because our slides can also take time to display them and consume our time. So thank you very much again for inviting me to this talk. As previous speakers said, the policies, the way we implement policies on health financing matter if we are to achieve universal health coverage. And the Abuja Declaration 20 years ago was meant indeed to provide enabling environment so that health system strengthening could benefit the resources that it requires. So without proper health financing policy, it's difficult to achieve universal health coverage. So in my remark, I just want to go back a bit to the study we did on national health account, the latest one, to share with you some of the indicators WHO was able to collect through the National Health Account 2017. Let me take the example of the way healthcare is funded. And from the last survey, we could see that we have noticed that healthcare is predominantly funded by household. The chair of the committee mentioned high out-of-pocket expenditure. Indeed, Nigeria is among the countries that have a very high level of out-of-pocket expenditure, thus impoverishing the population. So it was around 70%, and it has continued to go up from 2006 to 2017. Another indicator is the total health expenditure as a proportion of GDP. And in 2006, it was around 7.2% in Nigeria. So it has dropped dramatically between 2009 and 2010, and then it stayed at around 4%. The other indicator we analyze is the general government health expenditure as a proportion of GDP, which has remained around 0.5 and 0.7% between 2010 and 2017. If you look at the Abuja Declaration itself, which set a cutoff point of 15% of general government health expenditure as a proportion of all the government expenditure, and we saw that in Nigeria it started quite high. It was around 12%, but then it dropped. In 2017, it was around 4.2%, up from about 12%. So it shows like Nigeria as a country, as far as investing in health is concerned, has been going down and consistently. If you look at the other indicators, which also highlight the choice made by health financing policy, if we look at the current expenditure compared to the capital expenditure on health, the current is the salaries, expenditure on operations, basically, and the capital expenditure is training and investment. And we saw that the current investment represented more than 90% consistently, and in the 2017 it was even 97%, whereas the capital F expenditure was below 5%. So that's where we have infrastructure development, equipment, training of health workers. So it looks like most of the spending has been to pay salaries and pay operation, with minimal attention to the training of human resources and all other interventions. If you look at the way we spend on the different diseases, we could see that malaria was accounted for about 44%, followed by other diseases. But when you look at vaccine preventable diseases, where we have immunization, for example, it was just 2.7%. So you could see, and yet immunization is a routine immunization, for example, it's an important intervention to address under 5 mortality. If you look at another indicator, the proportion of spending on primary health care versus other level of care. And the primary health care was, the expenditure for primary health care were around 12% in 2010, up to 18% in 2017. And with primary health care being the basis, it should have been the other way around. We should have had 80% of our spending on primary health care, rather than having more spending on secondary and tertiary care. And that creates really issues in terms of meeting the needs of those in the grassroots level, the community. So the system, the policy in terms of spending, as far as health is concerned, do give the impression that Nigeria gives priority to specialized care, whereas the majority of specialized care could be averted if we invest better in primary health care. So I wanted to show you just these indicators for us to see where we stand. I know we are in 2020. Situation might evolve. I doubt that the COVID-19 might have improved the situation. It can only have worsened it. And this discussion is truly timely and relevant. We really need to rethink the way we spend on health. We can use better the resources that are already available by reallocating strategically. And as you know, yesterday, the World Health Assembly adopted the landmark resolution on operations and adopted a new framework for operationalizing, revitalizing the primary health care. This is a new development which Nigeria could take advantage of and accelerate toward better primary health care and universal health coverage. So my point here was to show how Nigeria is spending and how the current health financing policy could be revisited to make sure that we set the ground for truly acceleration toward revitalized primary health care and universal health coverage. Without proper policy in place, we are unlikely to reach the target. Today, we are 20 years after Abuja Declaration. We are still struggling, and we might go through a risk of adopting declaration after declaration if we don't revisit critically the way we've been spending. Thank you so much for this opportunity. My message, my plea was really for the Parliament, the National Assembly, to have a look into the way we are spending so that we could reallocate for better efficiency, giving priority to primary health care rather than to the secondary and tertiary care. Thank you very much, and over to you.
Thank you so much. That was really informative. And I appreciate the sharing of the indicators, particularly for our participants, so they can see how lopsided our health care financing framework currently is, and the need to readdress some of those, the way that we've been thinking around money and health and the priority that it should have amongst other things in the budget. So at this point, do we have the minister here? Or Dr. Gafar? No? Okay. Do they have a representative, or should we move into the interactive session? Okay, so our last panelist is Dr. Gafar Alawode. Dr. Gafar, can we see your face and acknowledge you this morning? Hello, Dr. Gafar. How are you?
Good morning, Dr. Nkem. Nice to be here.
Yeah, good to have you.
Thank you very much.
For those that don't know him, I'm going to introduce him shortly, and I know we'll benefit from his contribution. Okay, so we have, Dr. Gafar is a seasoned health systems strengthening and health financing specialist with more than 15 years progressive experience acquired through program implementation and technical assistance in developing countries, including Nigeria, Liberia, and Uganda. He obtained his MBS degree from the University of Ilorin, did a master's in tropical medicine at the Liverpool School of Tropical Medicine, and he was admitted into membership of the UK Faculty of Public Health through distinction. Dr. Gafar has led, has led processes of health financing policy design, and applied political economy knowledge to solve complex health financing problems, among other accomplishments. He has led several donor-funded initiatives, including the Global Fund, BFID, now FCDO, and USAID-funded projects as team leader, chief of party, and country director. Dr. Gafar, you are very welcome to speak and to present. Go ahead.
So once again, I would like to thank the organizers for inviting me to speak at this very, very important section. So the speaker before me said a lot of important things. I hope my slide is coming up. So just to add a few additional points to this very important discussion. So we have seen the data around where are we. I will not spend too much time on it. I would like to emphasize why are we here and what can we do to solve the problem. So next slide, please. So I'll quickly look at the financing situation in Nigeria, the impact of low prioritization, and looking at the bottleneck. Next slide. So this is an overview of health financing situation in Nigeria, looking at the key indicators. Most of across all indicators, we are not performing very, very well. If you look at proportion of government spending per person or per capita, which is 86 US dollar if you want to achieve universal coverage. In 2017, Nigeria did only 10, and even the Abuja Declaration, we are not there. Health financing, government health finance as a proportion of GDP, we expect it to be 5%. Nigeria did less than 1%, and proportion of people that are covered by a form of financial protection mechanism is less than 5%. Now, next slide. Let's look at the Abuja Declaration specifically. Now, if you look at since year 2000 till the year 2017, if you look at domestic general government expenditure as a proportion of general expenditure, is far lower than the Abuja target of 15%. Now, this indicator is very, very important because if we are just looking at government expenditure, there are some countries that are external donors actually subsidize their financing of health. So even if it looks as if they are achieving 15% Abuja declarations, might not be totally true. So until you unpack it and look at the government, domestic general government expenditure. So Nigeria is not there since 2000 that the commitment has been made. So next slide, if we look at Nigeria side by side countries of the same income group, if you look at other lower middle income countries, specifically we look at Commonwealth countries, on average, government contribute almost half of their expenditure. Private sector, out of pocket was only 38%. When you compare that to Nigeria, Nigeria's government contribution to current health expenditure was only average of 16%, and then out of pocket expenditure from 74%. So even when you put Nigeria side by side, countries of the same economic income group, we are still not doing very well. So what is the implications of these on our health outcome. Next slide, please. So you discover that, to start with, in the last 10 years or thereabouts, our maternal mortality ratio has been between 500 and 600 deaths per 100,000 live births. And this is largely attributable to the poor public financing of the health system. And then again, there's serious equity problem. Take, for instance, a woman from highest income group in Nigeria is 8 times likely to access skilled birth attendant than a woman from lowest income group. If we are talking about leaving no one behind, as a principle of universal health coverage, it shows that we have a lot of work to do. And there are problems in other areas as well. Nutrition, proportion of children with severe acute malnutrition that are on treatment is a very, very low proportion across many states in Nigeria. And there is even a huge regional variation in terms of other indicators, say family planning in Nigeria. Just to give an overview of the impact of low prioritization of health. Now, what could be responsible for this low level of funding that we are seeing? Next slide. So in terms of bottlenecks and recommendation, number one challenge is the fiscal constraints. Nigeria government tax to GDP ratio is one of the lowest in the world. Nigeria collects only 6 or 7% of its GDP as a tax, whereas the average for Africa is around 15 to 20. Now, let's put this in perspective. If we say Nigeria, for a country to achieve universal health coverage, they need to spend 5% of GDP. So how would Nigeria spend 5% of GDP when it only collects 7% of GDP as tax? So this is very, very challenging. So of course, we know that those of us in the health sector, there is little that we can do about this, but since we are talking to our lawmakers, I think it's something that we have to look at. How do we accelerate our revenue collection of government so that we'll be able to raise more money and increase the chance of allocating more money to the health sector. Another challenge, after interacting with the Central Budget Agency, Budget Office of the Federation, Ministry of Finance and others, that play a very, very important role in allocating funding for health. They seem to have the impression that health is not underfunded, which is a contrast to what some of us in the health sector believe. And their reason is this. They said, okay, those of us that are counting the numbers, we are not counting health spending outside the health sector, the health spending in the defense, in education, and others. So I think we need to come together to have a common understanding, and so that if we are saying health is underfunded, and the people that have the knife and the yam are saying health is not underfunded, we have to be on the same page. Another problem is low absorptive capacity. Even at the federal level, there are instances, despite the low allocation, there are instances that they will still return money to the treasury. So how can we convince the Ministry of Finance or Budget Office to spend huge amount of money when the Ministry of Health returns money? At least according to the Budget Office, that is the impression they give to us. Next slide. So, again, the low prioritization of health sector itself, I think it's a complex one, because if you have interacted with a lot of lawmakers, and they will say, if they go to their constituency and they ask the people what is their priority, they will mention like 5-6 things before they even mention health. They will mention physical infrastructure, job, even giving money to them directly and whatever. And in most cases, the politicians want to respond to what will give them more political capital. So we have to build a multidimensional investment case because health contributes to everything. Health contributes to economy, and in various ways. We should be able to engage Mr. President, because Mr. President wants to lift 100 million people out of poverty. There is no way this is achievable if we are not paying attention to health, because health cost is one of the major drivers of poverty level in any country. So we should not be changing ourselves in the health sector when we are talking about the importance of health. It transcends health sector itself, so we should be able to articulate a clear case. Lastly, we discovered that there is insufficient engagement with budget MDAs. There's usually disconnect between our health agencies and the budget MDAs. So we really need to close this gap so that we'll be able to make a very, very good case for health investment. And at the same time, we have to show efficiency and effectiveness of the little resources they've given to the health sector. So I'd like to stop here. Thank you very much.
Wow, thank you so much, Dr. Gafar. I think that your emphasis on what we can do about the problems is extremely valuable. I think and highlighting that our pool is a limited size pool because we're not able to collect revenue. So even when earlier it was mentioned that we can come up with special taxation, if the basic routine taxation we have not even mastered, not talk about special ones. So it will take some effort. Also, the impression that health is underfunded, is not underfunded is key. Because if you're hoping that people are going to fight for health, they can't fight for health if they don't perceive that health needs help. So I think that's obviously a very major observation. The other one is the low absorptive capacity within health. So if the ministry is returning money, clearly, if you're fighting for more money to be brought to you, you have to demonstrate the capacity to use the money. So I'm really looking forward to the interactive session. I'm sure people have follow-on questions that they want to ask about how we get beyond these things that are holding us back within the health sector. Okay, so I think we will move now to the interactive session. Is that okay? Okay. All right. So I will start with a few questions of my own. I have some questions that I would like to ask. So, Honorable Yusuf Sununu, sir, are you still available to answer questions?
Yeah, I'm available.
Sorry, you're with us?
I'm available. I'm with you.
Okay. All right. Thank you, sir. I have a question about health not being considered underfunded. I know that it's about perception. I think maybe the health sector has not done a good job in making its case to the National Assembly, but I think the National Assembly has a responsibility to look at acts that are being, bills that are being brought forward, to also appropriate the budget for health. And while I know we have...
You are distorted. What, can you ask your questions? Yes. I say you are distorted. I couldn't hear the question.
Okay. Can you hear me now?
Yeah, I can hear you.
Okay, so let me just go slow.
Yes.
So my question has to do with the perception that health is not underfunded, and how that somehow does it. I would like to ask if that influences how the National Assembly allocates, or should I say, when a budget is presented, how does that affect the appropriation process? This perception that health somehow does not need as much money as it's asking for. Have you seen such a situation where you've been on an appropriation and you've had to slash our budget because the perception is that we don't need as much money.
Well, because of network, I couldn't. I couldn't hear you properly. But I think you said whether the budget is underfunded, and how does the House do when such happens? You see, I quite agree with those who believe that the House is underfunded. If we have a target of allocating 15% to House, and what we come proud of now is allocating about a range of 5 to 7% over the period when the declaration was signed. We have to believe that it's underfunded. But you see, in our preparation, we look at a lot of things. We look at the fiscal, how the federal government come up with the budget. And then we also look at the allocations and priority areas. At times, you see some budget items that are not a priority or overbloated. In such a case, we now come with the questions. What are the key areas that require intervention? And how do we see where we can mobilize the excesses that have been pushed to where it's not much needed to where it can be utilized? Let's start, for example, the cancer treatment fund. When we came, we realized that there was a need for us to create that budget line because of its priority. So we have money for that cancer fund. Let me also look at in the revised budget. If you look at the revised budget proposal, there was money allocated in the budget for the molecular laboratory in senatorial district, 3 per state. Now, in our committee, what we raised the question, if the laboratories are established, who runs the laboratory?
Have we lost you? Hello?
Please. Who provide logistically difficult answer those basic questions? Allowing that to continue, we said, okay, let's change it right from the senatorial district to push money towards tertiary health institution, where you have infrastructure, you have the specialists, you also have an established lab but lacks capacity. So we now use that money to upgrade lab, rather than going for that lab that cannot be easily managed and handled. Okay. So these are the areas that how we see, we look at the priority areas and then see how we can allocate resources.
Okay.
Thank you.
Thank you very much.
Yes.
I think probably what I'm trying to get at is that the size of the pie, the Abuja Declaration is talking about prioritizing health to the point where it gets its 15% or more.
Yes.
Dr. Wada talked about public-private partnership as a way of expanding the pie. So the pie itself can be expanded. And I will ask you specifically about that too. But I'm saying that, in the advent that we don't have many voices speaking for us in the House of Representatives and the House and the Senate, where do you think the onus lies? Who do you think should take on the responsibility of fighting for more money? Is it at the executive level before it's even presented to the House, or is it at the House level that you think that the case can be made?
Yes, I've discussed that in one forum.
Sorry?
You see, it can be done before coming to the House, because we have an envelope budgeting system in the country. In an envelope budgeting system, you cannot take money from agriculture and all this to health. You understand? Except if you are going to make a provision of how to create more money by considering if the exchange rate is 350, you now consider, say, for example, you want to make it 352. The extra $52, $2 that you are going to you have generated, you can now say you are diverting it towards health. You understand? Or if the crude barrel or crude oil production is 1.8 as per the executive agree with you, can raise it to 1.88, and let's give you an extra barrel. And this extra money will now be tailored towards how you can move up to healthcare delivery. So these are some instances. But the right way is for us to come together so that we can work together and ensure that both the executive and legislative agree that more fund is needed for health. So that before the envelope is distributed to ministries, we can influence it so that at least 15% of the total envelope will now go to health. And that will reduce the minimal trying to interfere with the budget so that you get more money for health. And I think that's where we should focus for 2022. This I have discussed with the minister prior to our budget, that we need to have that roundtable discussion with both budget office, legislature, and health so that we can come together and agree that we need more money.
Yes. All right, thank you very much, sir. I appreciate it. We don't have anybody from the Federal Ministry of Health here. The questions I wanted to ask about how the budget, the health budget is determined, why secondary and tertiary sectors seem to be getting more money than primary health care. I don't think I can ask that of anyone who is spelled out now. But I can direct my next question to Dr. Ibrahim Wada, who very ably described the private-public partnership as a means to an end, and a very efficient means to an end. Our 206 million people would somehow ensure that we, in terms of dollars spent on health per capita, that number I think it will be difficult for that number to come up. It can come up, but that will take some time. What we can change now is the percentage of money from the total purse that is spent on health. That percentage can come up if we decide to. How it gets distributed amongst the members, our population, is a slightly different discussion. But we can certainly increase the amount of spending that is currently done in health. By the involvement of the private sector. From your presentation, it showed that there could be a potential expansion in the number of points that offer primary health care, being where 80% of our population get their care, and that the onus or the burden on government to provide all of this will be reduced, and then they can kind of go back to their regulatory, focus on their regulatory role. What I wanted to ask was how, apart from when you say that in Gariki Hospital, for example, that for the past 12 years, that no money was sourced from government in order to run it. What then exactly is the government doing for you in terms of this partnership? So they're giving you the infrastructure, but apart from the infrastructure, what else are you gaining from your partnership with the government in doing this?
I thank you, Doc, for this question. Part of the success of PPP is also building the capacity of government to understand what it's all about and to truly, willingly, and for the sake of the population, really join hands with the private sector and say, we are in this thing together. I'm afraid to say that that part of it, the educational part, the ownership part that says this is about the public and government has a responsibility, therefore let's work together, it became fractionated, unfortunately. The key reason is one government gave birth to the PPP, replaced by another government, and it became all sorts, as if the focus is not on the public, it's on the PPP. It should never have happened. So we were, if you like, if PPP is a marriage between a man and a woman to give birth to a child called Garki Hospital, we became the one-parent family overnight.
Okay.
However, 3 years, 4 years down the line, the ICRC came to life, given life by the National Assembly, and that was when we found a partner to help us bring this child up. I am pleased to say that the ICRC, that is the Infrastructure Concession Regulatory Commission or something like that, they've taken as much ownership as possible of the project, they've come to use all the instruments of measurement of compliance, measurement of success, and so on factors. And we, as the female partner, NISA Premier Hospital, working with the government, now feel a sense of parenthood, if you like, not just one mother child. So the government was weak. The government response and acceptability was weak at the beginning because of change of government in 2007. And then gradually by 2010, by 2010-11, the ICRC have taken note of us and we are working together. They keep encouraging us because it's a most difficult and new field. They can see the benefit, we can see the benefit. We hope to the Almighty God that the ultimate beneficiary is the public, neither of us, just the Nigerian public. Thank you.
Thank you so much. We're so interested in the model that was being used for Garrity Hospital, because it really is a potential template for other private hospitals to kind of key into the government's agenda and ensure that healthcare is accessible and affordable by most people. So thank you very much, Dr. Wada, for your contribution. I have one last question before I introduce my co-facilitator, who will be taking the bulk of the questions from the participants that are here. I have a question for Dr. Gafar, if you are still here. And that question has to do with what you see as the way to really address the revenue collection. What are the main barriers to revenue collection? As you know, that there's been a lot of talk about having innovative financing mechanisms to kind of supplement what's happening with the basic healthcare provision. People have talked about even the introduction of new vaccines, or even the people that are current Gavi that's currently helping to support the provision of vaccines in Nigeria, they start to withdraw their support. And you mentioned that other countries are somehow thinking about whittling down their support because they have their own health challenges with COVID-19. People are looking increasingly at innovative financing mechanisms as the way out. So what do you think we need to do as a country in order to strengthen our revenue collection framework? And how do you see these new and innovative ways of collecting monies from various sectors? How do you see them working? Thank you.
Okay, thank you very much. I think when we talk about revenue collection, there is part of it that is outside the health sector, the Ministry of Finance and budget office and all those stuff that are responsible for ensuring that there's an increased collection of tax. There's a recent Finance Act 2019, I think, which is looking at increasing the tax to GDP ratio. There are a number of measures outlined there, which we think if it is well implemented at both national and state level, there will be increased revenue as much as possible, because part of the problem is high informality in the country, where it's very difficult to raise tax from the informal sector. Now, having said that, so it's one thing for government to raise more revenue, and it's not done deal that once government raises more revenue, more money will be spent on health. So it now takes us the question of reprioritization. How do we reprioritize health? The first thing to do, I think all of us need to work towards putting health on the political front burner. It's extremely important at both national level and state level that the political class, especially the executive arm of government, see health as part of the overall development agenda, not just an expenditure on this specific sector. I think that's very important. But having said that, because it will not happen overnight, so we have to look at other measures, the innovative financing that you call it. The danger here is that we should not forget that if we work of coverage, public financing is very, very key. others can only complement. But let me mention one innovative financing which is on the horizon, and at the global level, everybody is talking about it. They call it blended financing. How do we use maybe donor money or government money to attract private investors by de-risking the sector? Because there are a lot of private sector people that have money that they want to invest, but they see health sector as a little bit risky. They don't understand it and all those stuff. So people are looking at how do we use donor money, government money to reduce the risk, so that the private sector will be able to bring their money into the health sector. This is one of several innovative financing approaches. There are other approaches which Nigeria is actually not leveraging on. Recently, they increased the excise duty for tobacco and others, but unfortunately, we are not proactive enough to engage at that level to see health should be part of it. So above all, it's very, very important to put health on the political front burner.
Yeah.
Over.
Thank you very much, Dr. Alawode. I think we still, as you rightly said, is one thing to generate all this money. If we don't have the absorptive capacity for it, we will lose credibility in health sector. So I mean, we clearly have our work cut out for us. Okay, so I would like to introduce.
Excuse me. All right. Yeah. I just have a question for Dr. Walter Kazadi from the WHO. Very quickly before, yes, sir. So part of funding for healthcare is donor funding is also considered a huge part of it, especially even in the context of the Abuja Declaration and otherwise. But we have seen a sort of reduction or a sort of reluctance. Reduction in donor funding, especially in Nigeria. I mean, when you compare even Nigeria and Ghana, in the health sector. So I just want to ask, what do you think about the reluctance of foreign donors to adequately fund the health sector in Nigeria? Are there things that we are getting wrong as a country? Are there things that we need to do to encourage that? Or are there things that we're doing that is discouraging donor funding in the health sector? Thank you.
Yes, thank you for your questions. I don't think there's a reluctance for donors to fund health in Nigeria. The decision to fund health and the economy in general, social protection, social sector, or health, they are also linked to the economic classification of countries. So as country move to low income, to low and middle income country, so they are expected to spend more domestically on some issues like health, education, and others. And it's part of the global economic architecture. So as the country improves the economic indicators, donors withdraw, because the donor funding is a kind of catalytic or mitigating while the country is rebuilding. So I don't see that as a reluctance. It's rather linked to the fact that Nigerian GDP has grown, and Nigeria is expected to invest more domestically. I hope I answered your question. Over.
Yes, Obina, you're muted, but Walter, that was a great response. That as we improve and as we take on these, as we position properly and allocate money to where it should, and as our economy strengthens, we kind of work our way out of donor dependence. So I appreciate that response. Okay, so I would like to move in. We're going to be moving into the interactive session proper with the questions that have already been put on the chat. Some of you will be selected to ask your question of the panelists live. Dr. Chioma Nwakanma will be taking over as co-facilitator here, and she will take it from there. Thank you.
Thank you so much, Dr. Nkem, and thank you. Hello, everybody. Welcome once more to this particular segment. It's been very enlightening for me, and I can say same for everybody. So at this point, without further ado, we'd just like to take questions from everyone who has been participating. I've seen the interactions so far, and I've seen that a lot of people have, I've seen some people making comments like, oh, I didn't know this, and I'm learning. So we're just going to take some questions, and some of them, from what I've seen, are directed to particular panelists, and then some of them are just general. So I think I'll just use my discretion to send that out. Okay, I think the very first question I'll go for would be, so we have one question here. It says, the Basic Healthcare Provision Fund was introduced in 2014 as part of the National Healthcare Act. It's overseen by three gateways: the Federal Ministry of Health, NHIS, and National Primary Healthcare Development Agency. So the asker wants to know, how effective has the fund been in bringing the promise of essential care, healthcare, to all Nigerians? I mean, since we started since the onset of the Basic Healthcare Provision Fund, how important, how has it been, how effective has it been in bringing essential healthcare to all Nigerians, especially those in the rural areas? I think this question would be directed to Dr. Ibrahim Wada, if he's here. If he's still here.
Yes, I am.
Okay, sir, I would direct.
I was listening to you about the Basic Healthcare Fund.
Yes. So we just want to know. I mean, I think
Hello?
Nigeria. Yeah. So this person wants to know how this has been effective. How has it helped us so far? What are the what are the loopholes, and how effective has it been generally? What can you say about this?
Thank you. I must really start by saying I'm not very qualified to answer that question, but I'm aware of a few issues surrounding the Basic Healthcare Fund. I think that it goes to support the primary healthcare system of the country, and it also goes to support the National Health Insurance Scheme. Unfortunately, the National Health Insurance Scheme is mainly government officials and their family are involved in that. It's not yet community-based widely. So maybe it's to help them to expand the National Health Insurance Scheme to involve more and more Nigerians in the private and the informal sector. So, but I think that gives an idea. Some amount of money is coming into the health system through the Basic Healthcare Provision Fund. But I think the main beneficiaries are National Primary System, Healthcare System, as well as the NHIS.
Okay, thank you so much. Yeah, I was going to direct the question to Honorable Yusuf, but he's particularly presently not here, so that's why. Okay, Dr. Nkem wants to say something.
I was going to say that you may want to ask Dr. Gafar that question. He has been involved in the writing of the operations of the media.
Gafar, are you here?
So Dr. Gafar,
yes.
Okay.
Okay. So thank you very much. To start with, I'll write on what Dr. Wada has just said. We should remember that despite the fact that the law, the enabling law for Basic Healthcare Provision Fund was signed in 2014, there was no appropriation until 2018. And money released in 2019, and later in the year, there was the National Assembly of the National Health Act that were not complied with in the guideline for the Basic Care Provision Fund. So it suspended since September, October last year until recently when the new guideline was resolved. So it's very, very early to start talking about how effective or efficient of the National Health Act, because in reality, we've not really implemented it. But the good news is that I think the Honorable Minister and the National Assembly, they've tried as much as possible to ensure the latest version of the guideline address a lot of issues, because the civil society, health workers, and line of the Basic Care Provision Fund. And then, so the revised guideline has taken that into consideration. So what all of us need to do now is to pay attention to its implementation, to familiarize ourselves with the guideline, and at the same time, in our various communities, to find out whether when those facilities receive the money, are the services being provided? Are they of good quality? And then there is even a grievance redress mechanism, so that if we are not comfortable with the quality of services that we are receiving, that we can approach appropriate authority to complain. So I think I can now say it is now that we are really implementing the Basic Care Provision Fund, and there is a plan for the by the Federal Ministry to be conducting what do you call it, town hall, virtual town hall, so that all of us will be able to participate in the process as much as possible. That's what I would like to say for now.
Okay, thank you so much. I think as a follow-up to what you just said, I would like to find out, you mentioned something about implementation, and I have to say, I think that's one major area that we've been found wanting as a nation. Now, you said something very important about, follow-up and finding out whether things that, things are in place in your own institutions or your own community. Are there I'd like to know if there are specific tracking tools for this. How can citizens monitor? How can people, someone who is concerned about monitoring Basic Healthcare Provision Fund, how can they track what is going on in their own communities, how it's being implemented, and also are there clear complaint channels, aside the virtual town hall you just mentioned?
So thank you. Like I said earlier on, there's a detailed grievance redress mechanism that actually highlighted what are the processes involved. If, for example, facility in my village, you've received the money that they are supposed to fix basic infrastructure in the facility, and on the health insurance part of it, if I access care, health insurance is supposed to pay for it. If all these things are not happening, so the grievance mechanism has highlighted, and I want to believe those people in charge of managing the Basic Care Provision Fund will disseminate these things widely at the facility level, because don't forget, at each of the facilities, there is a facility health committee, which are the representative of the people in each of the facilities. They are heavily involved, and they are supposed to be liaising with their community members. So if there are issues, committee should be the first point of contact. But at the same time, I want to believe as time goes by, they will place phone numbers where you can call. If there are hotline, you can call if there are issues and all those. But of course, it's not everybody that will be able to make that call. So interacting with the facility health committee to express concern regards to availability or quality, or is somebody still collecting money for services that are supposed to be paid for by Basic Care Provision Fund. I think those are the systems in place to check probably bad practices that can hinder the progress of Basic Care Provision Fund.
Well, thank you so much for that one, Dr. Gafar. You actually did justice to the next question I was going to ask you, which is about accountability of the stakeholders. And I mean, this is also a call to action for everyone who is watching, for the participants to know that, you know, knowledge is power. So at this point, we know that you can actually go over and hold the stakeholders accountable in your various communities. I think this is one way to keep every stakeholder on their toes. I'm just going to come right back to Dr. Ibrahim Wada. Sir, there's a question here for you. So they want to know, what have been the most difficult challenges with the PPP? You know, you have vast experience in this. So what have been the challenges that you have encountered so far in this practice?
Well, I think thank you so much for that question. The key challenge, I think, is carrying both sides to understand the true value that PPP will bring on board for the country. Advocacy to the public officers supposed to guard it, advocacy to the citizenry that are supposed to utilize the facilities. That was a key one. And I can imagine going back that in the days when the child was being born, there was even political turbulence. We were made to face Senate, we were made to face all sorts of things. But the other challenges are that they're common to medicine. That you have to provide your own electricity a lot of the time. You have to operate within set, if you like, set financial limits. That means even if there's one price hike for diesel, you cannot wake up overnight and change the dynamics to protect the project as you would do in a totally private place. There's that price sensitivity that somehow we are lucky because we were able to suppress any profit orientation to allow the idea to survive, because we knew that the country needed to look at PPP, whether they know it or at that time or they were not so aware of it. We had to make the PPP survive, and it has survived. That meant the idea of how much profit are you making from it had to be suppressed. So the dollar can go up, the prices can go up. We still struggled to stay within. That's another problem, another challenge that we had to meet. But thank God, the years are running, and we have meticulously kept documentation and told anyone that cared to listen that we cannot, as a nation, continue to do what we've been doing since independence that has not really helped the citizenry. We also address the sensitivity of the fact that we are about 200 million people now, and more than 4 million are being added every year. We can't be complacent. If we are to say we are as good as any other race, we must get together to address many, many, many options of getting to the promised land. And I think PPP, with all sincerity, is one of them. The challenges have been there, but the challenges have been overcome partly by sacrifice and partly by some level of ingenuity and forward-looking ideas. Thank you.
Okay. Permit me to both jump in there. I agree with you that PPP is a way forward for the health sector. I would personally like to see a situation where there's the proliferation of PPP projects across the country. I think that would be good for the sector. So you've identified as one of the challenges you faced the hurdles that you were made to scale, at the National Assembly. That's something that the participating committees are going to take back as feedback. But I also wanted to find out, besides the challenges you've mentioned, are there specific, what specific things would you request from the government as the executive and the legislature, in terms of ease of doing business? What actions do you recommend that they take to encourage the proliferation of PPPs in Nigeria?
Well, again, I think that's a very good one. I mean, the data that we have meticulously generated and protected have been made available. It's one thing to have a big hospital that is run by government It's another productive hospital that when people come there, they are happy, they are efficiently attended to, they go, their problems are solved fast. It's another thing to be in an environment where you come and after 2 hours, they're still looking for your file. So the first I could do was to protect the information, because it may not be our time. It may be other people coming after us that will use that information in a very positive manner to advance healthcare in the country. So these informations are available. The PPP does not agreement does not provide for me to go cap in hand to government. It says survive on your own. The idea is government does not have money to invest in this level of healthcare. So it's not that, hey, government, give me car, or give me motor, give me cash or anything. No, that's out of it. It is really one thing. For example, in the Federal Capital Territory, we had the key arrangement for transplanting kidneys, for which kidney transplantation, you've all heard about it, for which a lot of Nigerians, the moment you say you need kidney transplant, 2013, 2012, where's your ticket? Have you made contact with India? Are you this? So we said, at least let us stem that tide. And we got professors from abroad. We had good men on ground. All that it required was the system, the public system, to say, oh, wow, these people within a few years of being given this PPP have advanced to this extent. We are in this together. Hey, did you say you wanted kidney transplant? Come here. Our hospital is doing it. It wasn't so. So that's part of why that weakened. Anyone else coming after us will need to learn from that effort and say, oh, had it been that all the public hospitals in this place tied up with us and said, Nigerians don't have to go abroad to do kidney transplant, heart surgeries, which we were very fast in bringing to the FCT, we wouldn't be where we are now. But it's like live or sink, or, So these are the issues. Is owned by both the private and the public sectors for the good of the community, for the good of the people. And it must be driven into our head that whether it's private system that's running it and is doing it well, we should clap. That's Nigeria. Whether it's, whichever way you look at it. And my opportunity is to tell the people, you mustn't cross the shores unnecessarily if you can be helped here. And if you can be helped here, it doesn't matter if it's PPP or public or private, it's Nigeria. And that's a very difficult concept to sell to many people. But I think the PPP honestly reduces costs, gives more guarantees to the patients, it's not exploitation. Like a private is totally saying, where's my profit? Where's profit? PPP is not going to say, where is excellence? Where is fast progress? Where is advancement? Those are the first questions that PPP must ask, because you are responsible to the public. Thank you.
Thank you so much, Dr. Ibrahim Wada. That was really insightful. Lots and lots of questions here from the participants. I'm going to just go, before I come back to you, I'm going to ask a question. This is for Dr. Walter. Is he here? Dr. Walter, are you here? Okay, so there's a question for you. So people want to know, what ways can Nigeria, there was an earlier question, I think it was Opina that asked the question earlier about Nigeria and the funding, the international funding that we have, if there was anything hampering it. And then you said there was nothing of the such. So I want to find out, what ways can Nigeria obtain more resources, for funding of healthcare, since funding from international donors are dwindling? This is a question from Richard in Utako. So he wants to know what can be done, how resources of funding of healthcare can come for Nigeria.
Thank you for the question. As I said before, when I presented the indicators from the last self-account survey study, it will appear that the first thing Nigeria wants to do is think through the health financing policy and start the conversation about reallocation. We may need to use better, Nigeria may use to use better what it has already. On the example, if we are spending less than 20% on primary health care and more than 80% on the other level, so we need to revisit that. The proportion of funding spent on capital expenditure is very low compared to the other, general expenditure. We are spending more money on salaries and operations and very little money in investment, infrastructure, equipment, etc. Like Dr. Ibrahim was saying before, there's a difference between having a nice hospital, tertiary hospital, and having a facility that's providing the care that people need. It's very important to revisit, even before asking for more money, to revisit the way we allocate across all the indicators. We have seen there is a lot of allocation inefficiencies, and that one can be addressed through dialogue with the National Assembly. Then we could see the proportion of government's expenditures that are dedicated to health. Nigeria started with the Abuja Declaration. It started around 12, and the target was 15%. So it was a good start. But today it dropped to 4.2. So we may not expect, we cannot expect having a good outcome, health outcome, with that level of investment. So there is a really room for rethinking. Even donors and others who might come to help, they are also looking at those figures. We have also PPE, the presentation from Dr. Wada, which we need to explore. Nigeria need to consider how and what role can private sector play in terms of making services available. There are many industries here who can contribute as part of the corporate responsibility, social corporate responsibility. So there are many mechanisms. It really needs to be thought through even before looking into other donors. From outside, other stakeholders look at Nigeria based on the economic production and the foreign exchange, etc. So it looks like a rich country, but the way resources are allocated might be the thing that may need to be revisited. Over. Thank you.
Thank you. Walter.
Hello, Chioma, are you there? While she's reconnecting, I think there was something that Dr. Walter said that caught my ear about how countries are looking. They're watching to see what Nigeria does. When you're asking for help from outside, you need to demonstrate that you yourself, that you're working on the problem. It reminded me of a Ghanaian proverb that says, "You can't cry more than the bereaved." So, I mean, I think we look to donors a lot, but I think we have a lot to do domestically. So, Chioma, over to you.
Oh, thank you so much. Thank you so much for that one, Dr. Walter. So, someone wants to also find out. So he's saying, he's asking if you can throw more light on what you mean by secondary and tertiary spending. I know you mentioned in your presentation, and even right now, you mentioned about how we need to reallocate our spending and focus more on the primary health care. So he wants to know what you mean by secondary and tertiary spending as against the primary spending. Just maybe in a few seconds, if you could just give a little background. I'm sure a lot of people here also are wondering.
Yes, what I meant is, the health system, healthcare system in Nigeria is structured around the primary level, which is the world level with primary healthcare centers, and the LGA with the hospitals, the referral hospitals, and then the tertiary hospital, which are specialized institution. So looking into, again, here I'm quoting the evidence from the studies that was done. The last one analyzed data from up to 2017. And the data show that when we look at the health expenditures by level, the primary health care level, which comprise of primary health care center, etc., which is the first point of contact with the community, they accounted for something like 17% of expenditures. And the rest was the secondary level, meaning the hospitals, and the tertiary level, the specialized hospitals. So it gives the impression, just from the data, that the attention is more to specialized level of care, and with little attention to where most people get first encounter with the health services.
Does the government allocation to healthcare depend on revenue generated from the sector? So this is a question, I don't know if you're available to answer it.
Okay, so let me get it clear. The question was about, is revenue allocation to health, does it depend on revenue generated from health sector?
Yes.
Was that the question?
Yes.
Well, I would say to a large extent, probably no, because from what I know, especially federal level, so if you talk to budget office and other offices, they complain bitterly about even facilities not declaring or remitting. They are not supposed to remit, but at the same time, provide information about revenue generated and all those. So allocations are being made irrespective of what they are generating. That's part of our weaknesses, because what part some of us are clamoring for is that you have to use electronic financial management system to manage financial transactions at health facility as well, like what the private facilities are doing. So for many of the teaching hospital, general hospital, information about amount of money they are generating is like black box, which you don't know how much they are generating, what they are spending money on. So this is a huge area of inefficiency. And in terms of reforming, because I think part of what you need to emphasize here is not only about more money for health, it's about more health for the money as well. I think that's one area of reform that is very, very important. How do we make revenue generation from facility to be very, very transparent so that the facilities can use the money for to support the health care system? Let me give you an instance quickly. We look at the books of a lot of secondary health facilities in many states, and they are doing a lot of different facilities are using the money for different things. Some of them are so creative that they use their own IGR to build doctors' quarters, to buy ambulances and others, whereas others told us their IGR, they are only using it to buy diesel for their generator. And we are wondering, are you the only one suffering the problem of power supply and others? So I think this is a very, very important area we have to look at in terms of managing little resources efficiently. Over.
Okay, thank you so much. Thank you so much. So I think I want to ask a question. I'll just throw this question open. There's a question here from an anonymous attendee. He or she wants to know what measures are being taken to help the less privileged in terms of health care. So I think I'm going to just weigh in a little bit here, to just give a little more foundation to this. I think at this point we should discuss. We talked about the disadvantages is the high cost of care. That was part of the presentation Dr. Ibrahim Wada made, and he mentioned that the high cost of care is a challenge. However, the insurance is there, the health insurance is there. That begs the question, how many Nigerians are covered by the health insurance? What are the steps? We would like to know what are the actionable steps being taken to make sure that Nigerians are covered. Every Nigerian is covered by the health insurance. So I'm just going to either direct this to Dr. Wada or throw it open to anyone who can answer it.
Well, I can just say a few words about that. I think that the establishment of the National Health Insurance Scheme is a good one, and there are many private schemes that are coming on board. It's just a matter of not crawling, because the NHIS has been on since 2003, 2005. It came into activity. You're talking 15 years now. We can't crawl no more. We need to move. More community people, Nigerians. What it means is that you pay small monies every month, because apart from the government, you also have some responsibility to your health, just like to food and clothing and housing. Government can only help. So it's an avenue that allows you to pay a little into a pool of funds, into a purse, so that anytime you need healthcare, which is not every day of your life, there is a lot of money there to give you the very best at, spread your contributions. So it's the best possible thing. Is what every other great nation has used to be where they are, that we are pursuing with our tickets and going there. We are 200 million people. Even if it's 100 naira we are paying every month per head, just imagine how much that throws into the health purse. Allows us to train people, watch my lips. It allows us, with that steady amount of money available, to start producing the health things we need. Technology, I mean. So at the moment, it's a little bit wishy-washy. You don't know about this, but if the insurance funds are there on the Nigerian soil, many, many people will have the courage to say, I am establishing a plant that will make ultrasound machines, for example, injections, for example, all sorts, for example, because the money is there. So I want to leave it at that. The advantages of the insurance are beyond just reducing the cost. What is high cost today is 90-something% of healthcare is imported. And that's in dollars that changes value every day. So we must do something to put production on our soil.
Yeah.
If I'm allowed to add,
okay. Thank you.
Chioma, if I'm allowed to add,
just a few seconds
okay,
before I hand over to Obina.
A second.
Okay.
I guess the seconds just starting now. So, Dr. Wada is absolutely right. We are crawling. But we have to understand why we are crawling. There are major design defects in the National Health Insurance Scheme. The former sector that was launched in 2005, that was about the same time Ghana launched their health insurance, and today they've almost covered half of the population, and we are struggling with 5%. One of the problems is the legal framework that set up the NHIS then. There are two fundamental things that must happen in health insurance for it to be effective. One, participation must be mandatory. Two, there must be subsidization, because no matter how low, how little the premium is, some people are not just able to pay. I guess that's the insurance fund Dr. Wada is talking about. Number three, the NHIS was conceived as a centralized scheme in a politically decentralized setting like Nigeria. So the state were not buying in until recently, 2015, when NHIS now said, okay, let's decentralize the health insurance scheme. And that is why the state are forming their own state health insurance scheme. But at the same time, the state government needs to put what they call equity fund, because it's about universal health coverage. There are some people that are not able to pay. But above all, the governance is very, very important to provide very, very good oversight. I hope I did not exceed 1 second. Thank you.
Thank you so much for maximizing your 1 second, sir. I'm just going to hand over to Obina at this point, and he would promote some panelists. Thank you so much, Obina. Over to you.
All right, thank you, Chioma. Thank you, everyone. The contributions from our panelists have been so insightful. Like we all know, the essence of this session is to drive solutions. We want a solution-based conversation, more than just criticism. I must mention at this point that we have a session for to consider health insurance and tax-based financing of the sector. That is the 4th section, actually. Dr. Gafar, most of the things you addressed are the things that we actually need to, the recommendations you made are recommendations that need to be aired there so that the appropriate quarters can take the feedback. So in fact, let me even use this opportunity to extend an invitation to you to that session. It would be nice to hear your thoughts on health insurance. Also, well, from all the comments so far, from the presentation so far, it's clear that the issue in the sector is beyond just prioritizing health as making health a priority for the government. It also goes into the allocation, the internal prioritization of the funds in the health sector, like Dr. Wada kept stressing. It's important to look at how these things work. I know that we have, for instance, we have the basic minimum. We have the BHCF, that is the Basic Healthcare Provision Fund. And when we talk about funding of the sector, we know that statutorily, there should be an annual grant from the federal government of at least 1% of the consolidated revenue fund that goes into that Basic Healthcare Provision Fund. While that is not enough, we know that it's substantial. So you now have issues of how has it been implemented? How strictly have we kept to the 1% minimum? I don't think we've hit a full 1% actually. In fact, I noticed that over the years, the allocation, including the one in the recent budget, there's a steady decline. So this is feedback for the appropriate quarters to look into that. If we're talking about allocating funds to the health sector, then we need to, the laws, you have the good law that tries to put the government on its feet when it comes to funding the sector, especially with that fund. So we should need to look into complying with that. I also know that a key takeaway here also, especially from Dr. Walter's presentation, is that is our focus on our priorities. We're focusing more on recurrent expenditure, which is a problem always, and then rather than capital expenditure. We're also prioritizing more on specialized services and tertiary health as opposed to primary healthcare. And we know that about 40% of the Nigerian population, over 40% of the Nigerian population consists of the rural dwellers, and that's rural Nigeria. And these people, that's also one of the things we discussed in the health insurance conversation. These people don't know what health insurance is. And most of these people need primary healthcare centers more than tertiary, more than specialized care. And so these are the take homes that we need to, that the appropriate quarters are going to leave with. This is an interactive session. We want to hear, we have a lot of stakeholders from the various professional associations within the health sector. Very quickly, before we round up, we're just going to take two contributions from the attendees. If you know you represent any professional association and you're in the comment section, just raise your hand and then we'll just pick randomly two people who will be promoted to panelist status and just make a very quick remark. So if you represent any professional association, just raise your hand. Okay. We don't have time, so while we're waiting for people to do that, very quickly, I'll just make a few announcements. We are going to, we have two people. We have Andrew Inyama Iyali. So I'm going to promote you, Mr. Andrew Okama Iyali. I'll promote you. Introduce yourself, introduce the organization you represent. 30 seconds, make a quick comment, and then we'll also move on. Mr. Andrew, are you with us? Mr. Andrew, please turn on your camera and unmute yourself. Very quickly introduce yourself. Let us know the organization you represent and then make your comments. Thank you.
Okay, thank you very much. This is Dr. Andrew Yaji. I work in the Benue State University Teaching Hospital. And well, thank you very much for the presentation. I mean, your seminar, even though this period is work hours for us, but somehow I was able to get some snippets. My contribution is in the way of just two policies in the nation that I have always had the belief that can turn around our nation's health sector.
Okay. Yes.
One of it is a very effective primary health care, of which I heard you talk about. I mean, emphasis on primary health care. And then secondly is the funding, the very inclusive, health financing, health insurance. I think the health system is really fragmented in the country, and I don't know whether it should be less system, correct referral systems, and so on. I mean, if we have such, just these two issues, I think it will solve to a large extent our health system.
Okay. All right. Thank you very much. Thank you for the comments. The feedback has been received. It will be directed to the appropriate channels. Can we have one more person, just one more person before we round up? We're already way past our time. Okay, we have Frank Peace, Marvelous. Very quickly, introduce yourself, let us know the organization you represent, and then just make a quick remark. Thank you. Turn on your camera, unmute your mic, please. All right, we'll move on because of want of time. I'll just mention at this point that we have received the questions in the comment section, and the essence of this conversation really is to open up a steady channel of communication between the stakeholders and the relevant legislative committees. And that was the idea or the vision behind it, especially from the Media and Public Affairs Committee of the House, as well as our organization. And so the comments, I can see the questions that are here, that most of these questions are going to be directed. When we get feedback, they're going to be conveyed or communicated to you via email. I also need to announce that the second session for today will begin at 2 o'clock, where we'll be discussing building resilient systems in the context of the COVID-19 pandemic that we are battling to get out of. So I encourage everybody to join. The links will be sent to everybody via email. And we have a very great resource team that will be on ground to address that. So I think that's all for announcements. Permits me to hand over to the lead moderator to adjourn until 2 o'clock. Thank you.
Thank you very much, Ibrahim. So I would like to thank all the panelists that have given us their time and and have availed their experience and exposure and all the technical data that they have at their disposal for us to fully absorb the issues around prioritizing health in terms of financing and against the backdrop of the Abuja Declaration. So thank you so much, and I would encourage everybody who has been on this call to do your bit in advocating for health whenever you can. I mean, we're talking about, kind of defending the space, the fiscal space that health has at all quarters, whether it is at the facility level, at the state level, federal level, or for those of us that are speaking on behalf of the Nigerian health space outside Nigeria. I would just ask for you to lend your voice to this conversation. So thank you very much. Thank you very much, panel participants that have been active. Thank you for your questions and your interest shown from the kind of comments that have been made throughout. Thank you very much to the ACE Center and all your ability to coordinate all of this. And we really do appreciate the work that you're doing and promoting the discourse with legislators to ensure this translates into real policy.